Hey there, my name is Austin Marks and welcome to my YouTube channel. So my channel, I generally talk about respiratory therapy, talk about respiratory therapy school, and I also talk about what it's like being a respiratory therapist. So if you want to see any of that, make sure you like and subscribe. So I also post on my Instagram pretty much every single day. I kind of live my respiratory life through that. Also my personal life, if you want to see some of that, make sure you go follow me on Instagram as well. So I am also the admin of a Facebook group called the RT Club. And in this Facebook group, it's full of respiratory therapists, respiratory therapy students, and people looking to aspire respiratory therapy. We kind of all bounce ideas off each other, just help students out, and whoever may be looking into respiratory therapy and have questions. We just are a great community, so if you want to be a part of that, make sure you go join it. Once again, it's the RT Club on Facebook. So in today's video, I'm going to be talking about intubation. So what the heck is intubation? Why a person would need to be intubated, when not the intubated person. I'm going to talk about the procedure a little bit and everything that goes along with intubating a patient in general. So let's start off with what the heck is intubation. So intubation is when an artificial airway is put into the mouth or the nose and down into the trachea or the windpipe. Then this allows a person to breathe, or for us to breathe for a person. So why would we do this? So let's say a person is not breathing whatsoever. So let's say they go into cardiac arrest, or they get knocked out so hard and they're just not breathing. Maybe they were in a car crash, maybe they have a popped lung, whatever it may be, they're not breathing whatsoever. So therefore, this would be one reason why we would want to put that tube in and make sure the person can breathe. Now, we would do the breathing because the person would not be breathing on their own. So some of the reasons that we would want to go ahead and intubate someone is, like I said, they might have a popped lung, or maybe they got shot or something in their chest, they got hit real hard, they were in a car accident, they fell a few stories, or whatever the case may be. Maybe there's air where there's not supposed to be, that popped lung. Maybe they have blood going in and pushing on one of the lungs. If this is the case and it's bad enough, we will go ahead and put the tube in, as well as some kind of like chest tube or something to get that air out or that blood out, or maybe any other kind of fluid that may be building up in there, because we don't want any of that. We want our patients to make sure they can actually breathe adequately. So let's say that a person is not having a very easy time getting air in, so maybe they have something called epiglottitis, or they have a lot of inflammation in their vocal cords, some kind of edema or something, and they just can't get air in whatsoever. We'll go ahead and put a tube in that allows air to go directly into the windpipe and down into the lungs. Just that way we can deal with these issues without really having the person really be affected or having any issues with their breathing. The breathing will be under control and we can deal with just the inflammation up here. Another reason we may intubate someone is if they can't protect their airway. So let's say that they're having a seizure, so therefore they have no idea what's going on. Anything can go in there, the airway or into their lungs. And have you ever had something go into your lungs that's not supposed to be there, or anything went down the wrong tube? Doesn't feel so good. You cough it up right away and it gets out of there, hopefully. Well, if a person is having a seizure, they can't do this, and therefore that stays down there in their lungs and causes lots of inflammation, causes a lot of bad issues, and we definitely do not want that. So if a person is having some kind of seizure or any other kind of activity where they can't really protect their airway or cough anything up, we'll go ahead and intubate them. So another case where this may occur is if someone is having some kind of muscle issue. So maybe they have ALS, myasthenia gravis, or Guillain-Barré, just issues where they can't cough anything up or protect their lungs or the airway if anything would happen to get down there. This kind of goes along with the next incident as why we would intubate someone, and that's just because they can't clear their secretions. So once again, if someone has a muscle disorder and they just have all this mucus and just like, I can cough that up, right? They can't. So therefore it's like they're drowning in their own spit and their own mucus, their own gunk. And that's not fun. I can't imagine it being very fun anyhow. So we will put the tube in, and this allows us to put a catheter into that tube to go down into the lungs and get all that gunk out until the person is able to do that again, if they're going to have a positive prognosis, that is. So, as I said, some of the reasons we may intubate is if a person has ventilatory failure, so they're either not breathing whatsoever, they're in respiratory arrest, or they're breathing really fast, or just having issues breathing, ventilating. they can't clear secretions, so they're drowning in their own mucus and all their other gunk. They can't protect their airway, so they have the risk of being aspirated and getting stuff down in there that shouldn't be down there. And then the other thing I talked about was if a patient has some kind of obstruction in the upper airway and just air isn't passing through very easily, we may go ahead and intubate just to allow the air to get in there. So when we intubate, we generally use something called an endotracheal tube, and this is what one looks like here. So as you can see, it's probably about 30 centimeters long. It can either go through the nose or through the mouth, and then it will sit about 2 to 4 centimeters above the carina. Now, not everyone is going to be at the same length when we measure it from the teeth to the lip, just because we want to focus on where it's at internally rather than externally. I'm going to talk about that a little bit later in the video. However, as you can see, there is this little cuff looking thing, so that actually gets inflated with air. And what this does is it basically allows the tube to go into the windpipe, and then we put air into that little balloon and it inflates. That way nothing else can get in or out. That way the only thing getting in and out of the lungs is through that tube there. And then you can also intubate with something known as an LMA, or a laryngeal mask airway, or a king. So the LMA actually doesn't go into the windpipe at all. It sits on top of the larynx or the vocal cords. And this allows air to go directly into it. However, this is kind of used for like emergency situations or surgical cases where you don't really want to go into the lungs too much, or you just need to put something in because you don't have time to mess around and actually see what you're doing. You just want to get that airway going. Or we can also use something known as the king. So what this does is it actually goes into the esophagus and then blows up there. And then there's another balloon that blows up that allows air to go directly into the lungs. So once again, this is used primarily for like emergency situations. You just put that guy in there, that way we can make sure the patient is breathing adequately. There are several different tubes that you can use, I would say. There is a specific one where you can ventilate only one lung rather than the other. There's a bunch of different ones, however these were 3 main ones that I know about and that I've seen used before. So I am going to show a short video of someone being intubated or what it looks like.
I like to have all of my equipment laid out in front of me on the right hand side with my RT, and you want to go through each piece of equipment to A, make sure it's there, and B, make sure that it's working properly. The first piece of equipment is going to be suction, right? This is a Yankauer tube. You want to make sure that it's working, that it's connected to a suction canister, and that it's somewhere you can find it without needing to look. Oftentimes you'll run into vomitus or oral secretions or blood while you're looking at the vocal cords, and you want to be able to suction that out immediately. I'll take this and tuck it right here underneath the mattress or the pillow at the head of the bed. That way if I'm looking at the vocal cords, I can blindly just go and grab it. The next piece of equipment is going to be your laryngoscope. The laryngoscope is what you're going to be using to visualize the vocal cords. This one has a Mach 4 curved blade, which is my preferred blade. There are straight Miller blades that we'll sometimes use for peds, or if it's a preference of yours, you can use a Miller blade. I'll have a backup smaller Mach 3 that I'll use for smaller adults or children. You want to make sure that the light is actually working, right? That your batteries haven't died while it's been sitting in the drawer. So make sure that light source is solid and turns on every time you engage that blade. Your next piece of equipment is going to be your endotracheal tube, your ET tube. This is a 6.5, but typically I'll have at least a 7.0 and a 7.5 for my standard size adult. Sometimes bump it up to an 8.0 or 8.5 for a really large male, or it can go down to about a 6.5 for a smaller individual. But those are my standard go-tos, 7.0, 7.5 on the tray. They'll be close by if you need to switch it out. In terms of your endotracheal tube, you'll also need a rigid stylet, right? So this is a rigid stylet. It has an obturator on the end, a rubber obturator. And what you're going to do is use the stylet into the ET tube to give it some form so that you can manipulate it into the airway. And when you're going to be changing the form of that stylet, I like to have it like a hockey stick, right? So it's really straight, 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 straight. And right before the balloon at the end, you do a 35 degree angle anterior. That's going to help this tube go into the airway, which lies a little anterior. If it's too straight, you have a risk of it going into the esophagus. And if it's too angled, you're just going to get hung up on the vocal cords. You do not want it to go beyond the eyelet of the ET tube, right? So the tip of your stylet should not be protruding outside. That's going to cause damage to the airway. I tuck it in right before the eyelet starts on the ET tube. So now it's all prepped up and styleted. The next step is to make sure that your balloon is actually functioning, right? So I'll take a 10 cc syringe and I'll fill the ET tube balloon and make sure there's no air leaks. You can feel it. It's nice and tense. No air is escaping. At that point, you deflate it again so that you can pass it through the vocal cords easily. I'll set that to the side. My RT will know where it is, so it'll be ready. I want to make sure that I have a bag valve mask, right? It's the bag that you'll be attaching to the end of the ET tube to actually inflate the patient's lungs, and a mask, right? A mask is a good thing to have because if you run into trouble with the intubation and you need to oxygenate the patient in between attempts, well, you're going to bag valve mask them. And we show you how to do that in a previous video. The next step is to make sure you have your patient properly positioned. So I'd be at the head of the bed with my RT at the right, all my equipment at the right, my nurse at the IV line. We can all look at the monitor and monitor that patient. And then I'll have that patient's head right about the height of the lower end of my sternum. I don't want to be bending way over to see the vocal cords. It gets awkward and it makes it difficult. So bringing them up to the lower end of my sternum is just about right. You also want to make sure that you have that patient in the sniffing position that we discussed in a previous video. The sniffing position is a little bit of flexion at the head and elevation at the occiput. So you're really straightening out the angle of that airway, trying to make it as straight as possible for your look and for your intubation. In order to do that for your patient, you're going to, again, just flex their head as long as there's no C-spine precautions, just a little bit of flexion, and I'll often add a small pillow or a towel roll at the occiput to give that elevation. It really brings up the jaw and decreases that angle. Once they're positioned and everyone's ready, I'll have my nurse or my pharmacist push my medications, the sedative followed by the paralytic, and then you wait. You wait to make sure that your patient is sedated and paralyzed, realizing that this can take anywhere from 30 seconds to sometimes 1 to 2 minutes, so be patient. You want to make sure they're sedated because they won't be responsive, and the great way to figure out if they're paralyzed is looking for that laxity in their jaw. When you're moving their jaw and there's a lot of laxity, you feel that musculature kind of chill out, then you know you have good paralysis. And you're ready to move on to the next step, which is actually looking at the vocal cords. It's at this point that I'll remove the oxygen mask. I'll leave the nasal cannula just for some apneic oxygenation. You want to grab your laryngoscope, and when you hold it, I hold it in my non-dominant hand, my left hand, with the butt of the blade at my hypothenar eminence, 4 fingers grasping here, and my thumb on the handle for control. And when you're going to be using this, you're going to be doing a lifting motion, not a twisting motion, not a flexing at the wrist. It's really going to be an in and lift. I'll go to the patient's mouth. I'll oftentimes use my finger to pull that cheek so I can really get good visualization of the tongue. I'll place this blade into the right side of the mouth, sweeping the tongue towards the left as I bring that blade midline. And this part is where it's really critical. You don't want to be using the teeth as a fulcrum, right? You're not going to be flexing here. That's how you break people's teeth. It's really a in and a lift up. And I almost visualize it as I'm trying to bring that patient's chin to touch the sky. So I'm really lifting up here. A good 90-degree angle at the elbow and being close to the patient is going to help you make that move. And while you're doing that, you're looking, right? You're going to be looking for the epiglottis. Once you see the epiglottis, you want to tuck that blade forward into the vallecula, which will pop the epiglottis out. And then you can see the vocal cords staring at you, 2 white vocal cords. If you're having difficulty actually seeing the vocal cords, you can do external laryngeal manipulation where you're pushing down on the thyroid to bring the vocal cords into view. Once you've found them, you can have your assistant hold it there. Alternatively, you can actually move their hand and they'll hold it where you need to be so you can see those vocal cords. You keep your eye on it. You'll ask your RT for assistance. hands you the ET tube, and you want to watch that ET tube go through those vocal cords. And once you're in there, you want to go 3 to 4 centimeters beyond the vocal cords. Remove your blade. Hold that ET tube against the teeth with your hand while you remove the rigid stylet. And at this point, your RT is going to inflate the balloon, or you're going to inflate the balloon. We'll put on our end-tidal CO2 detector once that balloon's up. And you now want to confirm that that ET tube is in the airway.
So as you can see, they basically open up the person's mouth and they go ahead and they can see the vocal cords and they go directly in there. And this will bring us down into the trachea, and we don't want to go into the lungs. We actually want to sit above the lungs 2 to 4 centimeters. That way we can actually ventilate or give air to both the lungs. So respiratory therapists aren't always the ones intubating. So personally, I've never intubated. I've intubated a mannequin, but I've never actually intubated a person. Some schools will allow their students to go into operating rooms and intubate there. There's a facility 50 miles away from me, and their respiratory therapists are allowed to intubate. However, where I work, anesthesia does it. Therefore, I just mainly control the mechanical ventilator and all that other stuff. So anesthesia comes, they intubate, they make sure the airway is in place, and then I'm in control from there. However, I am going to go over the steps of intubating just so you have an idea of what it looks like, even though you just saw that video. So to start, you want to make sure that you have all your supplies, because you don't want to be in the middle of intubating someone and then be missing something that's very key, because that'll be a huge problem, and if things go badly, that'll be very bad on your end as well as the patient's. So first off, you want to make sure the cuff or the little balloon works, to make sure that the nothing is going to pass through that little pilot balloon, it's called. You want to make sure that it'll inflate and deflate before you even do anything. You want to test your equipment before you use it. Once you do this, you want to explain to the patient what's going to happen. However, as I said about all the indications, you don't always have time to talk to the patient about what's happening. You just need to go ahead and act because it's an emergency. However, if the patient is awake, and you talk to them, you explain what's going to happen, this makes the patient a whole lot more comfortable. Plus, I don't want someone talking to me if they're putting a tube down my throat personally. And then while you're getting everything ready, you want to have someone basically bagging the patient is what we call it. However, this is basically when you put a mask on the patient with a bag hooked up that's getting a flow of oxygen through it. And this allows you to breathe for the patient or assist in their breathing if they're still awake. And this just allows them to get tons of oxygen in there, because we need as much oxygen as we can get. It's very, very important to pre-oxygenate the patient before you decide to intubate or before you sedate them. So at this point, your patient is getting all the oxygen they need. You will go ahead and put sedation at this point. So sedation is basically medication that knocks the patient out, because I can't imagine it being very comfortable if we would have to put the tube in while the patient is awake. There are times when patients are awake and not sedated with the tube in. However, putting the tube in at first, you want sedation. So I'm not going to go over all the drugs in this video and when you use what. That's a little above the scope of this video. However, here's a list of a couple. These are very common drugs. They're used, as I said, there are different purposes as to why you would use each individual drug. So once the patient is knocked out, you want to put them in something called the sniffing position. So this is basically when their head is back and their neck is up, and when you are behind them looking in their mouth, you have a clear visualization of everything that's going on. You know exactly where the tube is going to go. So once the patient is in this position, you will take the bag away or have the person bagging take that away, and then you go into with the laryngoscope or the gyroscope as well as the tube, and then you have a clear visualization of the vocal cords, and then you will go in through there, you go down into the trachea, and like I said, you do not want to go into the lungs. You want to stay 2 to 4 centimeters above the lungs. So remember that, 2 to 4 centimeters. So if it isn't exactly 2 to 4 when you're looking in because you can't see all the way down the trachea, that's okay. As long as you are actually in the trachea or in the lungs, it's okay. You just want to make sure the tube is in place. And how do you make sure the tube is in place? So we will do something called capnography. I believe this is the most common thing. So there's something called color capnography. So basically you put this on the end of the tube, and as you're breathing for the patient, they're obviously having gas exchange going on. So if enough CO2 comes out, it'll change the color of that little thing that you put on the end, or you can hook them up to a capnography machine that automatically reads it. So if you're getting something above 10, like in a cardiac arrest situation, anything above 10 is okay, and if you're consistently getting above 10, that's great. However, if you're not getting anything back at all, it's reading 0, 0, 0, could be a problem. Something else you want to do then is listen to breath sounds. So, like I said, you're breathing for the patient. So are those lungs inflating and deflating? You want to make sure that air is actually going in and out, in and out. And if you can hear those breath sounds and you got a good capnography number or a good CO2 level, you're good to go, you're perfect. However, you're not hearing breath sounds and nothing is happening on the capnography machine, that's a bad situation. That means that you're probably in the esophagus, and you're not going to get any gas exchange if you're breathing or putting air into the esophagus, because all that is doing is putting air into the stomach. That person's belly is getting bigger and bigger and bigger, and guess what? They're not getting any oxygen whatsoever. So if you don't fix this problem almost instantly, that's a bad day for that person. So therefore you need to act accordingly, pull the tube out, and just redo the whole thing over again. There's no rhyme or reason why you should freak out. Yes, it is a problem. However, that's part of our profession. We are basically told not to freak out in emergency situations. We deal with emergency situations all day, and we gotta keep our cool because that's how these patients live. So going back to actually having the endotracheal tube in place, and having that pilot balloon and all that, you want to make sure you have a syringe and you can put air in. That way no air is going around it, because if you put the capnography machine on the end of the tube, it didn't inflate the pilot balloon, guess what? All that air is going to go around the tube and out the mouth rather than going straight up the tube and out the tube. So you want to make sure that you inflate the pilot balloon as soon as the tube is in place. You get a chest x-ray as soon as possible, because like I said, you want to have the tube 2 to 4 centimeters above the carina. So if you do intubate into the right lung, that's okay for a brief moment, because here's a chest x-ray of someone who had that tube into the right lung for way too long. You can see it doesn't look so hot, does it? You're only giving the right lung air. You're only ventilating the right lung. So look at that left lung. It's just not good at all. Bad situation. You want it to be 2 to 4 centimeters above the carina. Cannot express that enough. That is real life stuff, as well as for the TMC or the CSC, 2 to 4 centimeters is where you want that tube. So I talked about all the indications, I talked about the procedure of actually intubating. You guys even saw a little video. So when do you not want to intubate? So let's say someone got shot, like right in the cheekbone, their airways all messed up, full of blood, you have no access whatsoever, you can't see anything. It's probably not a good idea to intubate. So in this situation, they'll most likely do a trach or something called a cric, which is criciotomy. So that's when they go in right here and they get access to the airway that way. So you always got to remember that your airway is in front of your esophagus. So you're never going to go through your esophagus. You're going to reach the airway before you get to the esophagus. So the only reason you do a cric or anything like that is if you have no access whatsoever. So like I said, a lot of facial trauma, you can't see what's going on, or there's a whole lot of inflammation, especially in the vocal cords, and you have a very slim chance of actually getting it through the vocal cords. Don't even mess around. That patient needs to be breathing right now, so go ahead and do a cricoid or a criciotomy or a trach, and just make sure you have access to the airway, because like I said, if a person isn't breathing, that's a bad day for everyone. Another issue you may run into is if a person has some kind of cervical spine injury or a fracture back there, because you can't always put them in the sniffing position, you can't move their head around or anything like that. So therefore, if you don't have access, you can't see, don't move their head, because if you do, this can end in a very bad situation. It can cause a lot more problems. Yes, the breathing is essential. However, there's other ways to have the patient breathe, as I just mentioned. So go for the trach, go for the criciotomy. Don't even mess with intubating and moving their head all over the place. And lastly, if a patient has a DNI or a do not intubate, this person does not want to be intubated. So respect their wishes. Don't intubate the patient. So some of the most common things I see people being intubated for, and I believe this is the most common, would be if someone's going into ventilatory failure or some kind of failure with breathing. So someone who has a CHF exacerbation, COPD exacerbation, they roll through the ER. They are obviously having issues breathing because they have a lot of fluid in their lungs or a lot of inflammation, whatever it may be. They just can't breathe whatsoever. So something we would definitely get is something called an ABG, or arterial blood gas. And this allows us to look at the CO2 level for these patients. So if the CO2 is above 50 and the pH is below 7.3 or 7.25, this will be a good indicator that we need to intubate this patient, just so we can get everything under control, so we can control their breathing and get everything back to normal. So sometimes, if a patient looks like they can come around, I will put them on something known as a BiPAP machine. So this is known as non-invasive ventilation. And when you intubate someone, this is known as invasive ventilation. The only really big difference is that with invasive, it is invasive, you have the tube going down your trachea. And with non-invasive, with BiPAP, it's that mass that's going on, and that's how the person's breathing. So I'm gonna make a whole nother video talking about BiPAP, the settings and all that other stuff, so make sure you stay tuned for that. So with a lot of these patients, you would just wanna see how they're trending. So if they come in and they've been getting worse and worse and worse for days, you may wanna go straight to intubation. Sometimes you put them on BiPAP and that's not helping whatsoever, they're still trending downwards, go to intubation. You want to get an overall visualization of your patient, and if you're a student and you just now kind of getting the idea of intubation, that's probably why you're watching this video. It may be a little difficult at first, however, I see patients come to the door and the doc will say, "Hey, Austin, what do you want to do?" I say, "Let's intubate, we need to intubate now." And generally they listen to me and we will go ahead and intubate the patient. A lot of other common things that I see is cardiac arrest, we will intubate patients, or I work at a trauma center, so a lot of traumas come in, and if they can't protect the airway, they're not breathing on their own or anything like that, the trauma doc will say, "We need to intubate ASAP, let's go ahead and do that." So anyway, if I missed anything, if you're a respiratory therapist watching this, please leave a comment. If you guys learned a little bit, which I hope you did, please leave a comment as well. Make sure you guys like it as well, leave a thumbs up. Well, anyway, I hope you enjoyed this video, and I'll see you in the next one.